much for me to share. Yeah. I have a potential conflict of interest from Miriam from Philips. So today we are going to talk about firstly the general overview of mitral anatomy, and then subsequently we will talk very briefly about 3D echocardiography, and then we will explore the specific anatomy for mitral registration and also mitral stenosis. So my subspecialty, I'm actually an adult in cardiology. So today I'm going to learn from you as well. I'm sure all of you are more expert in the pediatric cardiology field than me myself, so we will learn from each other. But I'm specializing in structural heart disease imaging, especially in the echocardiography guidance of structural heart intervention, especially using the transcatheter approach. So in the National Heart Center Singapore, we do a lot of surgical intervention, mostly adult cases, and also transcatheter intervention. For example, for mitral clip, for the valves, the mitral, we do mitral clip procedure. We also do a tricuspid intervention, tricuspid clip valve, which is a heterotopic valve implantation. So we put in the valve in the inferior and superior vena cava. We also do a pulmonary valve intervention. These are mainly for adult pediatric congenital heart disease. And transcatheter aortic valve intervention. We also do a lot of device plugging of multiple holes, be it in the paravalvular leak, electroseptal defect, ventricular septal defect as well. And in the past couple of years, we also do prosthetic valve removing in the patient as well, and also left ventricular appendage closure. So a lot of things that we do now, we can do transcatheter way in the structural heart imaging. So just a very brief overview of mitral valve anatomy. As we all know it, it is the most posteriorly located cardiac valve, and it is far-field from transthoracic echocardiography imaging. And this is especially a problem when we have a prosthetic valve located anterior to the mitral valve, and this may cast echo shadow into the mitral valve. And because of the posterior location, it is very optimal for transesophageal imaging. So if you look at the mitral valve anatomy more closely, the next question is, what is mitral annulus? Anteriorly, the mitral annulus actually has no specific structure. It is located at the aortomitral curtain, and the location is roughly defined by the hinge point, where the movement of the anterior mitral valve is. So over here, I marked it with this red triangle, and on the CT image and the 3D echocardiographic image as well. So this is a typical representation of an on-class 3D mitral valve view, which we will see again and again later on. So A1, A2, and A3, starting from the lateral, middle, and medial part of the valve. So posterior annulus is actually the convergence between the atrial and ventricular muscular wall as a fibrous skeleton of the heart, and externally is the we call it epicardial adipose tissue. Looking at it more closely, we now appreciate that the mitral valve is a complex three-dimensional structure. It is actually not flat, it is more shadow-shaped in morphology. There is an anterior peak that is located at aortomitral curtain, and the posterior peak at the infralateral left ventricular wall. And the nadir point is actually at the fibrous trigones, which is at the commissural location, the anterolateral and the posteromedial commissural location. And this three-dimensional structure is disrupted in mitral valve diseases, especially in the functional mitral registration. So using a three-dimensional echocardiogram, we can assess the morphology of the mitral valve, which we will have a look later on. And this can provide insight about the mechanism of mitral regurgitation, especially the functional type of mitral regurgitation. And this will also help for intervention, especially those with transcatheter intervention, but also for surgical intervention. So just a very brief overview of 3D echocardiography. In two-dimensional imaging, we actually take frame of image, and we have what we call as frames per second. In 3D echocardiography, we actually take a volume of image, and the larger the acquisition volume, and the wider the image is, there will be a longer acquisition time, and therefore you have a lower temporal resolution. At the moment, three-dimensional echocardiography still have lower resolution than the two-dimensional echocardiography. So this is one of the limiting points, but it's getting better and better in the recent years. And as you can see here, to improve the volume per second or the time resolution, we can actually do an ECG gating imaging. And ECG gating imaging can have a potential artifact, which is what we call as a stitching artifact, because the images are actually taken from multiple different cardiac cycles and then stitched together. So these are some of the artifacts that we will see later on in a couple of my examples. The first one is actually the stitch artifact that we mentioned earlier on. The second one is the dropout artifact. The dropout artifact is basically a poor echocardiographic signal strength from a particular location of cardiac structure. For example, a very thin valve, and you will see this artifact as if there is a hole in the three-dimensional image. And you can confirm it by one of the examples is turning up the gain, or by turning on the color imaging to see whether there is any color doppler flow across the what looks like a hole. The next echocardiographic artifact that is very important is actually shadowing. We also see this in the two-dimensional echocardiography, but also very important in 3D echo. So if you have some echo reflector anterior or more proximal to the probe compared to the structure that you are evaluating, then you will have what we call as shadowing and limited imaging of the structure of the breast. Okay, so let's move on to the cases. So this is a classical classification that is not very useful of mitral regurgitation. We use Carpentier classifications. So type 1 is when the leaflet motion is actually normal, but there is an abnormality in the leaflet structure itself or the subvalvular apparatus. So one example is leaflet perforations or crack, and this is probably the most common in the pediatric patient. And also in some secondary MI where the leaflet motion is actually normal, but there is a disruption in the three-dimensional morphology of the mitral annulus resulting in mitral regurgitation. Type 2 is when there is an excess in leaflet motion, for example in mitral valve collapse. And type 3 when there is a restriction in motion of the mitral valve leaflet. For example, in patients with ischemic cardiomyopathy, with tethering or the posterior leaflet resulting in mitral regurgitation, or in patients with rheumatic heart disease with limited motion of the heart leaflets. This is very important for clinical decision making regarding the follow-up and subsequently the treatment strategies as well. So this is just a quick comparison of the epidemiology or the classifications, the causes of mitral regurgitation in both pediatric population and in adult population. In pediatric population, most commonly is because of congenital abnormality of the mitral valve system itself. For example, a pure ventricular septal defect, clefts, and dysmorphic valve. And this is getting less and less common in the adult population because of the improving care for the pediatric patients. And most valves that have severe abnormality has been detected in the pediatric age before they move on to adult life. Mitral valve prolapse also still common in the pediatric population, and in adult this is probably the most common cause of regurgitation. Rheumatic heart disease in the past has been the most common cause of mitral valve disease, but it's declining number in the recent years. Of course, the rest that is less common, infective endocarditis and aspic herniation in the older patients, and secondary mitral regurgitation, for example, cardiomyopathy, ischemic heart disease, and atrial functional mitral regurgitation is much more common in the older patients in the adult population. I'm sure everyone are very familiar with the classification or the grading criteria for mitral regurgitation. And this is actually especially important in the pediatric population because of different body sizes. So it's not as easy as classification in adult populations. You have to have a look at the body size of the patient, different stages of growth as well. But just very briefly, I think the first thing that we need to look at is actually the morphology of the mitral valve leaflet itself. When there is a severe morphological abnormality, it is more likely to be a severe regurgitation. The second one is actually looking at the size of the jet compared to the size of the chamber. So when it is occupying a large portion of the left atrium, more likely to be a severe regurgitation. And also the duration of the mitral regurgitation. Just a limited duration or hollow systolic duration of the regurgitation. Of course, there is also some semi-quantitative criteria that we use. And the other criteria that we use is actually the impact of the chamber itself. So when the left ventricle is dilated, or when there is severe mitral regurgitation, the left ventricle is more likely to be dilated. So what are the goals of mitral valve imaging? And I always keep this in mind when I start my imaging for a patient, be it the transthoracic or transesophageal echocardiography. The first one is really to assess the valve morphology and the pathophysiology of the regurgitation or stenosis. The second one is focusing on severity, the grading of the severity. I'll then assess also the left ventricular size and function, and also left atrial size. Pulmonary pressures is also important to be assessed. Subsequently, we need to keep in mind what are the potential management strategies that we need to take. Is this valve more suitable towards surgical management? When do we do the surgical management? Now, or can we wait for longer? And if we are considering for transcatheter therapy, it is even more important to think about whether the morphology of the valve is suitable and approachable for transcatheter therapy. So let's look at a couple of examples. So in the next couple of minutes, we will talk about a lot of examples. So the first patient is 35 years old, male patient with no past medical history. He has mitral regurgitation and first presented to us because of cardiac pneumonia. He is asymptomatic, but there is a very poor transthoracic imaging and uncertainty in the MR severity. Therefore, we do transesophageal echocardiography. So this is one of the typical PE position that we do, mid-esophageal location, and we look at bicommissural view. So this is medial commissure, lateral commissure, and this is actually somewhere around in segment 2, the middle segment. So when we cut using orthogonal simultaneous imaging, you can see the corresponding leaflets, which is at the A2 segment and B2 segment. And we can see here that the tip of the T2 segment is prolapsed, and there is a flail segment as well. And because of that, there is a mitral registration. And this mitral registration is very eccentric and eerily directed with quanda effect, where the registration jet actually follows along the wall of the left atrium, indicating that the registration jet is significant. So this is an illustration of the structure of the mitral valve when we image it this way. So biconventional imaging, T1, T2, and T3, and a simultaneous orthogonal imaging as such. That's what we discussed earlier on. And this is when we actually use the 3D imaging. We can actually appreciate that not only there is a prolapse and flail of the T2 segment, we also see that there is a cleft between T2 and T3 segments with a small mitral registration jet. And this is a very important consideration during intervention, especially a transcatheter intervention. Also during surgical intervention, we really need to let the surgeon know that there is this cleft that can potentially open up when they are intervening on the prolapse and fail P2 segment. And using multi-parametric approach, we actually concluded that this is only in a moderate severity, and we follow up the patient further with imaging and monitoring. The second case is an elderly gentleman with diabetes, hypertension, and hyperlipidemia. He also has a chronic kidney disease. The cardiac history-wise, he has ischemic heart disease. He presented to us with evolved inferior myocardial infarction, and he had a stenting done to the right coronary artery on the day of admission. On day 3, he suddenly developed acute pulmonary edema. On transthoracic imaging, there is an acute mitral registration. So this is the transesophageal imaging. Intraoperatively, this patient was brought to the theater emergently for a mitral valve intervention. So what we can see here again, mid-esophageal TEE at a biconventional view with simultaneous orthogonal imaging. And you can see here in the medial part of the valve that there is a flail segment here. You can see the anterior leaflet is flail with some echogenic structure attached to the tip of the leaflet, which is actually a ruptured papillary muscle. And this results in severe mitral registration. With three-dimensional echo, we can see very clearly that the whole medial segment of the anterior mitral leaflet, both in the A2 and A3, is prolapsed and flail, resulting in severe mitral registration. So this is a very nice diagram of the structure of the mitral valve and the attachment of the cordae to the papillary muscle. As we know that the anterolateral papillary muscle actually holds the lateral half of the leaflets, and the posteromedial papillary muscle holds the medial half of the leaflet. So in this patient, the anterior head of the posteromedial papillary muscle is ruptured, resulting in prolapse and fail of both A2 and A3 segment. Okay, this is the next case, which is a ventricular functional mitral registration. Less common, but I'm sure that this is also present in some of the pediatric populations, especially those with cardiomyopathy. So this is an elderly gentleman again, 60 years old, diabetes, hypertension, has a previous stroke, has a chronic kidney disease. He has ischemic heart disease with previous presentations of heart failure symptoms, and has a fecal vessels coronary artery disease, and was deemed to be high risk for surgery, therefore multiple statins was performed in the past. This is a transthoracic image. You can see very low left ventricular ejection function. That's severely reduced LPEF. And the left ventricle is very dilated. Yeah, and you can see that there is what we call a tenting form of the mitral leaflets. Yeah. So both the anterior and the posterior leaflets are actually tented pulled towards the ventricle. And the regurgitation jet is actually along the coaptation line, especially towards the medial location. And there is a posterior more than anterior tenting, resulting in a posteriorly directed mitral regurgitation. So this is just an illustration on how we can use a three-dimensional echocardiogram to assess volumetrically the ventricular function. So this is a left ventricular ejection fraction assessment volumetric using a 3D echocardiogram, and the EF is 33%. We can actually show this in the afternoon hands-on session on how we can use a 3D echo to assess the LPEF. So this is the PE image of the same patient. As we discussed earlier on, there is a tenting of the mitral leaflets, posterior leaflet more than anterior leaflet, and medial more than the lateral segments. And this is because of papillary muscle displacement and enlargement of the left ventricle. And we can see here that the jet is a little bit larger in the medial location. And because of this, the jet is actually along the coaptation line, and the origin of the MR is not circular as compared to degenerative MR with mitral valve prolapse. Therefore, if we do a two-dimensional PISA method or pinna contractor method, we may underestimate severity of the mitral regurgitation. So this is, I cannot stop it. So this is a 3D, what we call as a multi-planar reconstruction. So you can really position the lines in the 3D space to specifically look at different locations of the mitral valve. In this example, actually, I've done a reconstruction so that it cut at the level of the pinna contractor. And this is the long axis view, and this is the short axis view. And you can see that the origin of the MR is not circular, it's more along the coaptation line, elliptical in shape. And using a 3D pinna contractor actually is more accurate in assessment of mitral regurgitation that is not circular in origin. Okay, so this is a diagram of ventricular function of mitral regurgitation. The leaflets are tented. In symmetrical tenting, you get the central coaptation gap with central MR, but in the predominant posterior tenting, like the example that we gave earlier, there is a posterior eccentric MR, or what we call as anterior leaflet pseudoprolapse. The next one is actually atrial functional mitral regurgitation. I think this condition is very, very rare in the pediatric population. Usually, we see this in the older patients with chronic atrial fibrillation. So this is a very old female patient, 87 years old, with a history just hypertension, otherwise she's healthy. She has a cardiac history of atrial fibrillation for the past 20 or so years, and she has severe mitral regurgitation. Look at the structure of the heart, very different from the ventricular functional mitral regurgitation. In this patient, the left ventricle is relatively preserved in size, it's not very dilated. But the left atrium and the right atrium are very severely dilated. And there's also dilated mitral and fractured valve annulus. And the valve morphology is flattened instead of the saddle shape that we discussed earlier, or the normal saddle shape that we discussed earlier. So this is a long axis view. You can see the coaptation is almost like a 4D to tip palpation within anterior and posterior leaflet. And in this patient also has an anterior pseudoprolapse appearance, resulting in posterior really directed MRJ. This is the TE image for the patient. Again, appreciate that it's a very pattern palpation line as compared to a normal patient. And definitely, if we compare it to the earlier example of ventricular functional patient, there's a lot of tenting. This one is actually really flat palpation, very dilated annulus, resulting in palpation gap. In the 3D image, very clear, very flattened palpation gap, resulting in mitral regurgitation. There is actually all of palpation line. So this again a diagram to show that the difference between ventricular and atrial functional mitral regurgitation. So atrial functional regurgitation, key features, there is dilatation of the atrium. The annulus is very dilated. There is no significant tethering, no tenting. Usually it's central jet dispersed along the palpation lines, but you may have asymmetrical tethering because of atrial dilatation, resulting in anterior pseudoprolapse and posteriorly directed MRJ. And the left ventricle ejection fraction and size is typically near normal. Okay, so let's move on very briefly to mitral stenosis. In pediatric population, mitral stenosis is not uncommon and mostly due to congenital abnormalities, parachute mitral valve, for example, or supravalvular stenosis, dysmorphic valve, and these are typically coexist or associated with other anatomical abnormality of the heart. In adults, again, less common. Rheumatic heart disease, declining number, even in the pediatric populations, and in adult, this is still one of the most common cause of mitral stenosis, although the number is not a lot. Pacific degeneration, this is just for adult. I'm sure everyone are also very well aware of mitral stenosis and the effect of mitral stenosis to the cardiac structure. So this is an example of a patient with rheumatic mitral stenosis. So a very typical appearance on transthoracic two-dimensional echocardiogram. This is the parasternal long axis, and we do simultaneous orthogonal imaging trying to actually cut at the tip of the leaflets during the study to assess the mitral valve opening area. But as you can see, this is not a precise way of doing it. If we do a three-dimensional echocardiogram and we do a multi-planar reconstruction, you can really assess at the diastole at the maximum opening of the mitral valve and really at the tip of the mitral leaflet, there's the mitral valve orifice area. This is the image of the same patient. You can see here where I draw the green line. We are actually trying to cut exactly at the tip of the mitral valve leaflet during the maximum opening in diastole to really get the accurate mitral valve area measurement. Okay, the next one I'll give a very brief example on how we use the 2D and 3D echo to guide intervention. So pre-procedurally, it is very important for diagnosis and severity grading, and also to assess the suitability and the strategy for intervention. In the procedure, we need to give live guidance, especially the transcatheter procedure, or even for a surgical intervention. We do a pre immediately before the surgery and post-surgery to assess for results and whether there is any potential complications from the procedure. And of course, in the post-procedure phase, for long-term monitoring of intervention results. So this is a very complex case of mitral valve prolapse, which we treated with microclip. An elderly male gentleman with diabetes mellitus, hypertension, advanced chronic kidney disease approaching a dialysis range, and has a stroke history as well. He has a severe symptomatic mitral agitation and was deemed by the surgeon to be high risk of surgery due to the chronic kidney disease and history of stroke. So under transthoracic imaging, we can appreciate here in the short axis mitral valve that the origin of the jet is very medial. It's actually in a conditional location with a very laterally directed end of jet. And then the explained imaging at APT3, the AP and P3 leaflets looks okay, but there is one leaflet that is hanging on top of it, which this is a very suspicious look for conditional collapse. So we perform trans-esophageal echocardiogram and confirm the finding as well. Very medial origin of the mitral agitation with very laterally directed MR jet. So this is medial and this is lateral, where the left atrial appendage is and the left upper pulmonary vein. And there is a prolapse and flail of the posteromedial conditional segment with this very laterally directed MR jet. In 3D imaging, we can appreciate the same finding. Prolapse and flail of the posteromedial commissural segment, and this is from the atrial perspective, and this is from the ventricular perspective. Okay. So what we plan to do is actually what we call as an edge-to-edge effect using a device that is called microclip. So the clip, what we hope to do is actually to capture one leaflet and the other leaflet with the other arm and bring it together to close the mitral agitation origin. Yeah. So this is a picture of microclip device. And to be able to do this safely and effectively, we need to really image the locations where we want to put the clip. Yeah. And as we can imagine, when it is at the commissural location, it's very difficult to image. Very difficult to really cut perpendicular to the caudation line in a commissural location. So we use a 3D multiplanar reconstruction to achieve this. And over here, we really cut at the medial segment, AP and PT. This is the bicommissural view. This is a long axis view. You can see P3 segment and AP segment, and the overhanging segment on the top is actually the flail medial commissural segment, as confirmed on the 3D on fast view as well. So we brought in the device, the clip, and using the same MBR view, we actually do a grasping and capture and closing of the clip in all two-dimensional multiplanar reconstruction. As you can clearly see here, again, the creeper, which is a device to capture the leaflets position. Subsequently, the clip is closed to close the origin of the mitral agitation. So this was done as a live guidance during the transcatheter intervention exam. Okay, so in summary, we have discussed about the mitral valve anatomy. It is posterior located valve, and imaging is actually optimal to image the posterior valve location, and it is a shadowed-shaped configuration, complex morphology, and this is instructed in diseases. We have also discussed about mitral agitation and stenosis, mostly in the adult population in my examples, but we have also discussed about the different etiologies of mitral agitation and stenosis in pediatrics and adult population, and how we assess morphologically and severity. We also discussed about the anatomy, imaging, and techniques with consideration of valve intervention. So thank you so much. And I will appreciate if you have any questions, can always approach us. And I'm very happy to be here to meet new Vietnamese friends and also friends from Philippines as well and from the hospital. Thank you.